Hello all, myself Swati Dhande and I will be today introducing you with pharmacotherapy of bronchial asthma. So at the end of this session, you will be able to explain what is bronchial asthma, you will be able to discuss pathology of bronchial asthma and you will be able to enlist drugs along with their mechanism of action for treatment of bronchial asthma. So, bronchial asthma, it is a chronic inflammatory disorder of respiratory system. It is a condition of recurrent reversible obstruction of airway and this is going to lead to bronchospasm, excessive and thick mucus formation, hyperresponsiveness as a result of epithelium damage and airway remodeling as a process to improvise the damage which is caused, and in this process there will be loss of elasticity. So, what is the pathology behind the bronchial asthma? As we know, it is the inflammatory process, so in this case it is the allergen. This allergen is going to get introduced into the body. Once it is inside the body, it is going to activate IgE. IgE is immunoglobulin E, which is responsible to cause, which is the antibody and which is going to cause mast cell degranulation. This mast cell degranulation is going to lead to a huge array of histamine release and different inflammatory response. This both are further going to contribute to epithelium damage. Because of this epithelium damage, the lower tissue which is having cholinergic receptors will get activated. And in this inflammatory response, the leukotriene release is going to contribute along with cholinergic receptor to huge bronchoconstriction. So, we are now aware of what is the pathology of bronchial asthma. Now, we are going to further lead to what are the different approaches to treat this bronchial asthma. I want you all to write down the possible approaches considering the previous slide where we have talked about the pathology of bronchial asthma. Alright, so probably you must have already thought about these different mechanisms. So let us see what are the approaches. As we know, activation of IgE takes place, so we can have the drugs which can block this. So we have anti-IgE antibodies which can be given. Then again we know mast cell degranulation taking place, so we can give membrane stabilizers. We know that as inflammatory response, so we can have the drugs which stop that. So anti-inflammatory drugs can be introduced. There is leukotriene release, so we can have drugs which can modulate leukotriene release, so leukotriene receptor antagonists and synthesis inhibitors can be given. We can give specific cholinergic blockers, so we have muscarinic receptor blockers which can be given, and ultimately we can take care of bronchoconstriction by using different bronchodilators. So beta-2 agonist and xanthine derivatives are the one which can be given. Okay, so now let us discuss one by one these different drugs which can be actually used in treatment of bronchial asthma. Very first which we have seen is anti-IgE antibodies. Remember, in this case, there will be no sign and symptoms which can be seen when there is IgE activation in the pathology. So what happens is this drug can be just given as a prophylactic agent. Drugs like omalizumab is being used. This drug is going to form the complex with IgE. This complex formation is going to lead to the Fc region loss of activity. This Fc receptor is mainly responsible to bind to mast cells, and because its activity is being lost, we cannot see mast cell activation and hence degranulation can be hindered there itself. Next, what we have are the membrane stabilizers. These membrane stabilizers are again going to be used as a prophylactic agent. The drugs like nicorandin, nidocromil can be used. Its mechanism is it inhibits mediator release from bronchial mast cells and there will be further no inflammatory response. Next class up, we are having the anti-inflammatory drugs. So mainly corticosteroids like fluticasone propionate can be used. Now this class can be used in acute as well as chronic type of asthma. Its mechanism is basically it is going to inhibit inflammatory mediators. Along with that, it can decrease vascular permeability and epithelial damage. So overall, it is going to reduce bronchial hyperresponsiveness. Next, we have the leukotriene modulators. Basically, we are going to have leukotriene receptor antagonist. Example is montelukast, and leukotriene synthesis inhibitors. Example is xylitol. These both drugs can be used in case of chronic asthma. Mechanism, because they are leukotriene receptor antagonists, they are going to block cysteine leukotriene 1 subtype receptor, while the synthesis inhibitors are going to inhibit the LOX, that is lipoxygenase enzyme, the one which is responsible for formation of leukotriene. The main drugs, bronchodilators, that is beta-2 agonist. Now these drugs can be used to get rid of the bronchoconstriction which has been caused because of a huge cycle of inflammation and allergy. So this beta-2 agonist, we have it into two types, short-acting and long-acting. Short will be for 2 to 6 hours and can be used in active acute bronchospasm, while long-acting have 12 to 24 hours action and they can be used in chronic asthma. Short-acting ones we have salbutamol, terbutaline. Long-acting we have salmeterol and formoterol as example. The mechanism is simple, they have to bind to beta-2 receptor and that's why they are going to lead to bronchodilation. Along with that, they are also going to take care that they are going to enhance the ciliary mucus clearance. So this is the dual action which has been exerted because of this beta-2 agonist. Next are the xanthine derivatives. They are also having almost similar action, but their intensity is less as compared to that of the beta agonist. Drugs include theophylline and aminophylline. They can be used in case of chronic bronchial asthma. Mechanism, they inhibit phosphodiesterase, the enzyme which is responsible for activation of 5-MeO. So that's why this is going to further lead to bronchodilation. They are also able to facilitate the mucous clearance. Next is muscarinic receptor blockers. Now these drugs include specific M3 activity. They are going to inhibit M3. Drugs are ipratropium, tiotropium. These drugs again will be preferred in case of chronic bronchial asthma. Mechanism, inhibit specific M3 acetylcholine receptor and hence they can block further bronchospasm. They can also contribute to reduction in mucus secretion. With this, we come to the summary of drugs which can be used in bronchial asthma. So to conclude, we can say that we have two classes, relievers and preventers. Relievers are basically short-acting beta-2 agonists and anticholinergics which can be given very well for the acute type. Preventers and controllers include long-acting beta-2 agonists, corticosteroids, leukotriene modifiers, mast cell stabilizers, and lastly anti-Ig antibody. With this, we are at the end and I thank you for your patience listening. Thank you.